So CorMicA is a British Heart Foundation study on patients with angina but who don't have any visible blockages in their arteries. And we performed this study because it's a very common problem. So if we look around the world at patients that are undergoing a clinically indicated angiogram, up to half have nearly normal or no obstructive lesions in the arteries. And when these patients are having their standard care procedure, the diagnosis is variable. So when you've got a negative angiogram, the treatment varies from physician to physician, and the patient leaves with a lot of uncertainty. And so we address that with the clinical trial. So the study design was a wee bit complicated, so I'm just going to go through that slowly. We recruited all comers with angina who were having a clinically indicated angiogram. And we asked for their permission to go in the study if they were found to have no obstructive disease. So they were having a clinically indicated angiogram, and we got permission to do tests only if the coronaries looked unobstructed. So once we had done the angiogram, if they had no obstructive lesions, and that was based on the visual interpretation of the angiogram and the use of FFR. So if they had no obstructive lesions, they were eligible for randomization. And we randomized patients into one of two groups. So we had an intervention arm, and these patients had a special interventional diagnostic procedure. And put simply, that procedure was designed to diagnose microvascular angina, vasospastic angina, or on the other hand, to rule out any of those disorders. So to either diagnose microvascular angina, vasospastic angina, or normal coronary function. And each of those diagnoses has a distinct treatment. And the treatment guidelines that we issued our physicians with were based on ESC guidelines for the treatment of these disorders. The control group, on the other hand, was quite a unique group because they also had the same interventional diagnostic procedure, but it was performed in a blinded fashion. And that involved the use of a second cardiologist. So a second cardiologist came in after the patient was randomized to the control arm, performed the test, so potentially a sham control, but the results of the tests were not given. And so they were allowed to be treated as the physician wished, and the physicians also had the same guidelines on treatment. I guess it's just important to point out that diagnoses like vasospastic angina or microvascular angina are not often made in standard care, and that was really the hypothesis that we were testing. Could we identify disorders of coronary function and make patients better by diagnosing them and treating them appropriately? So the primary outcome was a Seattle Angina Summary Score. So that's a patient-centered metric of angina severity, and we assessed that in all patients at 6 months. We found that the intervention and stratified treatment led to improvements in angina by around 12 units in the summary score, so almost a difference in CCS class of 1. So quite an important clinical difference between the groups at 6 months. And we found important secondary endpoints, including improved quality of life and improved treatment satisfaction in the group that was randomized to having the intervention. There were other important secondary outcomes. Physicians will wonder, what's the utility of these tests? So we wanted to look at whether these tests changed the diagnosis, and we found, interestingly, that 50% of the physicians' diagnoses were changed through having these tests. So quite striking. In addition, in the control arm, a misdiagnosis of microvascular or vasospastic angina occurred in 36% of cases. So put a different way, 1 in 3 patients in standard care are walking out the cath labs with a misdiagnosis of a treatable heart condition. So I think first and foremost, we can now diagnose disorders of coronary function in the cath lab. And these disorders of coronary function are common and not identified in standard care. So this is a mechanistic study, and I think we do need more data. We need perhaps a multi-center randomised trial. We had 151 patients with no obstructive disease. We recruited 391 patients with angina, but I think it does need to be replicated, and we'll be looking to do that in a bigger series.